Welcome again, everyone. Today we are diving in the same chapter, but part 2, which covers also the parental nutrition support. We will explore the complex clinical and ethical decisions surrounding this life saving therapy. Let's start by looking at our learning objectives for this session. In this second part, we will give you examples of individuals who may be candidates for home nutrition support. And we will tackle the ethical issues in nutrition care and identifying the principles that guide treatment decisions and comparing the responsibilities of physicians and patients during medical emergencies. Let's set the stage by looking at the history and the clinical context of this therapy. Administering parenteral nutrition. Parenteral nutrition is a complex treatment requiring skills from a variety of disciplines. To handle this, many hospitals organize specialized multidisciplinary nutrition support teams. These teams consist of physicians, nurses, dietitians or nutritionists, and pharmacists. They may, they may manage the nutrition supports directly, or they might serve as advisors to the other clinician. Let's look at the specific roles of the team member. Within the team, the physicians. The physicians diagnoses medical problems, coordinates and prescribes the therapy, performs medical procedures, and directs to the teams. While the nurse plays a critical hand on role, assessing nursing needs, performing direct patient care, explaining medical procedures, and coordinating discharge plans. Meanwhile, the dietitian or nutritionist and pharmacist handle the nutritional and pharmacological specifics. The dietitian assesses the patient nutrition status, determines their exact nutrient needs, recommends the appropriate diet therapy, and instructs the patients, while the pharmacist recommends appropriate drug therapy, identifies potential drug or diet drugs interactions, and educates patients about their medications. The first major procedure step they face is placing the catheter. Insertion and care intravenous catheters. While skilled nurses can place catheters into peripheral veins, only qualified physicians can insert catheters directly into central veins. Patients may be awake and given local anesthesia for this procedure. To reduce complications, the complication risk, nurses must strictly use aseptic techniques when inserting catheters, changing the IV tubing, or changing the addressing that covers the catheter site. What happens if things go wrong at the catheter site? Catheter related problems frequently cause complication. These include air leaking into the bloodstream, causing an air embolism or blood clotting at the catheter tip. Catheters can become clogged, improbably placed, or dislodged. They are also leading cause of infections and sepsis, which might be indicated by redness, swelling, or an unexplained fever. In peripheral veins, they can cause phlebitis or tissue injury. Assuming the catheter is safe, how do we initiate the flow of nutrients? So, initiating and advancing fusion. The method or protocol to initiate parenteral nutrition depends entirely on the patient's condition, potential complications, and specific hospital protocols. One methods or one approach is to start the every infusion at every 2 to 3 days, or I can say the methods start the infusion at a very slow rate and increase it gradually over 2 to 3 days of the period. Another method is to give full volume of a nutrient dilute solution on the first day and advance the nutrient concentration as the patient tolerates them. If there is no risk of fluids overload or hyperglycemia, solution can often be started at full volume and full strength immediately. We also have to decide the timing of the infusion. Continuous versus cyclic parenteral nutrition. In acutely ill patients, parenteral solutions are usually infused continuously over 24 hours. This is called continuous parenteral nutrition. However, patients requiring long-term support often receives infusion 8 to 14 hours periods only, known as cyclic parenteral nutrition. This allows more freedom of movement during the day. The use cyclic infusion, patients must be able to tolerate the nutrient dense solution required to meet their needs in a shorter time period. Regardless of the schedule, strict monitoring is required. Before starting any infusion, the clinical team must perform all the nutrition assessment, recording baseline height and weight. They must check laboratory value, including blood glucose, triglyceride, electrolytes, and liver enzymes or liver functions enzyme. The nurse must verify the solution label to ensure the component and expiration date are correct, visually inspect the bag of, for defects, and most importantly, confirm catheter placement by the X-ray. Once the infusion starts, the monitoring schedule is rigorous. So the routine patient monitoring. Every 4 to 8 hours, vital signs are checked. The catheter site is inspected for information. The pump rate is verified and blood glucose are tested. There is other routine daily. The team must replace the parenteral solution and tubing, monitoring the patient's weight change, record all fluids intake and output, and check the lab or the laboratory until the patient is stabilized. Several times a week, the patient's overall nutrition status is reassessed. Eventually, we hope the patient improves enough to stop the IV. Discontinuing parenteral nutrition. Before parenteral nutrition can be trapped off, the patient must have adequate GI function and minimal risk for aspiration. Transitioning to oral diet can be tough because a person's appetite remains suppressed for several weeks after terminating parenteral nutrition. So, switching to nocturnal cyclic feeding can help appetite during a day. Generally, the parenteral infusion can be discontinued once about 60 to 75% of the patient's nutrient needs can be provided by enteral or oral means. Now, let's look at the metabolic complications that can arise during treatment. Metabolic complications require rapid intervention. Potential metabolic complications include electrolytes imbalances, refeeding syndrome, hyperglycemia, hypoglycemia, hypertriglyceridemia, liver disease, gallbladder disease, metabolic bone disease, and nutrient deficiencies. Let's review the most common issues starting with blood sugar. Hyperglycemia occurs when blood glucose level exceed about 180 milligram per deciliter during infusion. This most often happens in patients who are glucose intolerant, experiencing severe metabolic stress, or receiving corticosteroid medication. Because you know, corticosteroid medication increase the blood sugar level. We prevent it by providing insulin along with parenteral solution, avoiding overfeeding and restricting the amount of dextrose. In a critically ill adult, dextrose infusion are strictly limited to less than 5 milligram per kilogram per minutes for the critically ill patient and adult. The opposite problem is hypoglycemia. Hypoglycemia is rare but requires attention. Hypoglycemia is uncommon but can occur if parenteral nutrition is abruptly interrupted or discontinued, or if excessive insulin is given. In patients at risk, such as young infants, feeding may be carefully tapered off over several hours before stopping completely. Alternatively, clinicians might infuse standard dextrose solution at the exact same time the parenteral nutrition is interrupted to keep blood sugar stable. What about issues with fats? Hypertriglyceridemia. Hypertriglyceridemia may result from either dextrose overfeeding or overly rapid infusion of the lipid emulsion. Patients at high risk include those with severe infections, those with liver disease, those with kidney disease, or those with hyperglycemia. If a blood triglyceride level exceed 400 milligram per deciliter, the lipid infusion should be reduced or stopped altogether. One of the most severe complications occurs in severely malnourished patient. Refeeding syndrome. Severely malnourished patients who are aggressively fed can develop refeeding syndrome, which is characterized by fluid and electrolyte imbalances and hyperglycemia. It happens because dextrose infusion spike insulin levels, which quickly remove phosphate, potassium, and magnesium from the blood. This can lead to fluid retention, cardiac arrhythmias, muscle weakness, and even heart or respiratory failure. To prevent practitioners provide only half of the patient's energy requirements initially, advancing the dose gradually over several days while carefully monitoring the electrolytes. Long term therapy affects major organs as well. For the liver disease, fatty liver frequently results from parenteral nutrition, though it usually corrects itself after the infusions are discontinued. However, long term parenteral nutrition can cause progressive liver disease and eventually liver failure. Patients at highest risk have pre existing GI or liver disorders, malnutrition, or severe infections. To minimize the risk, clinicians avoid giving excess energy, dextrose, or lipid, and utilize cyclic infusion when possible. Is the gallbladder and bones are affected? Yes, gallbladder and bones are also affected. When the GI tract goes unused for weeks, sludge, which is thickened bile, builds up in the gallbladder, eventually leading to gallstones. Patients may need medication to stimulate the gallbladder contraction or may require surgical removal of the gallbladder. Furthermore, long-term long-term parenteral nutrition is linked to metabolic bone disease, causing lower bone mineralization and density. So intervention involved adjusting nutrient, adjusting medication, and incorporating weight-bearing physical activity. For patient, for patients whose condition have stabilized but still need support, we look at the home setting. So nutrition support at home. Some individuals require nutrition support even after their medical condition has stabilized and they no longer need hospital services. Current medical technology allows for the safe administration of nutrition support in the home, provided by medical equipment companies and home infusion providers. This is a massive benefit as it allows patients to continue receiving specialized nutrition care while leading normal lives. However, the patients or their caregivers must be capable of learning the required procedure and managing any complications. Who are the candidates for home support? For home enteral nutrition, candidates are people who have disorders that prevent food from reaching the intestines or interfere with nutrient absorption. Example include individuals with severe dysphagia, gastroparesis, gastric outlet obstructions, or condition causing malnutrition or malabsorption. Sorry. Active individuals often prefer low profile gastrostomy or jejunostomy tubes because they allow a much more normal lifestyle compared to transnasal tubes. For parenteral support, the candidates are slightly different. Candidates for home parenteral nutrition are individuals with disorders that severely impede nutrient absorption or interfere with intestinal motility. This includes conditions like short bowel syndrome, radiation enteritis, and chronic bowel obstruction. Because this is a long therapy, it requires access to the larger central veins, with the catheter exit site usually placed on the chest wall. Most patients prefer to transition to cyclic infusion before they are discharged from the hospital. Planning this care requires coordination. So planning home nutrition care. Planning involves making decisions about access sites, about the formula, and nutrient delivery methods. And it is crucial that users are involved in this decision making to ensure compliance. The portable pumps are extremely useful because they free individuals from having to remain stationary and can be used when traveling. For parenteral solution, safety is paramount. Solution must be sterile and specifically prepared, meaning individual who mix their own solution must be very carefully trained. Despite the benefits, this take a toll on the patient's quality of life. Quality of life. Users and their families often struggle with severe lifestyle adjustments. The treatment are expensive, time consuming, and inconvenient. Work schedule, travel, and sport must be heavily planned around feeding. Physically, people receiving nocturnal feeding complain of disturbed sleep due to noisy bump, bathroom visit, and discomfort from being hooked up. Socially, the inability to consume meal with family and friends causes great stress and a loss of comfort and socialization. Managing these patients also bring us to difficult ethical question. The availability of specialized nutrition support forces healthcare professionals and society to face difficult ethical decisions. Medical technologies can sometimes prolong life by merely delaying death, leaving the patient with extremely low quality of life. We have to ask if providing nutrition care does little to promote recovery, is it appropriate to withhold or withdraw it? To answer this, we rely on stabilized or established ethical principles. The core ethical principles. Clinicians must consider several principles. The first, patient autonomy. Patient autonomy is the right of the patient to make decisions concerning their own well being, even if refusing treatment result in death. Disclosure and informed consent. Disclosure means fully informing a patient of risk and benefit, which leads to informed consent. Number three, decision making capacity means the patient is mentally capable of making these decisions. The principal beneficiaries dictates that the potential benefits must outweigh or potential harm. And finally, this distributive justice requires that providing care to one patient doesn't unfairly limit care to the others. When do these principles conflict? Dilemma arise when patients are dying or unlikely to regain consciousness. Under these circumstances, life sustaining treatments may be considered futile because they will not improve the medical outcome or increase the patient's comfort. Conflict occur if families demand treatment that practitioners view as useless or if medical personnel find it objectionable to withdraw life support. Keep in mind When a patient's preferences are unknown, the medical staff is legally obligated to provide any available care likely to sustain life, including nutrition and hydration. These conflicts have led to landmark legal cases. The legal decisions: Cruzan and Schiavo. Two landmark cases illustrate these dilemmas. Nancy Cruzan was in a persistent vegetative state for years. Her parents sought to remove her feeding tube, leading to 1990 Supreme Court decision that emphasized the need of explicit advance directives. Decades later, the Terry Schiavo the Schiavo case involved 15 years legal battle between her husband and parents over removing a feeding tube, which eventually involved a Florida legislature and the United States Congress. Both cases highlight the intense legal and emotional battles that occur when a patient's wishes are not explicitly known. This brings us to the importance of advanced planning. To prevent these tragic battles, individuals are highly encouraged to declare their preferences in an advanced healthcare directives, sometimes called a living will. They can also use a durable power of attorney to appoint a healthcare agent or a proxy to make decisions in the event of incapacitation. These directives only take effect if a physician determines the patient lacks decision making capacity. Unfortunately, despite their availability, less than 30% of people in the United States have actually completed an advanced directive. Finally, let's discuss the DNR and organ donation. DNR order and organ donation. Do not resuscitate or resuscitate DNR order. Order is used specifically to withhold cardiopulmonary resuscitation in the event of the cardiac arrest. It is important to know that a DNR doesn't automatically exclude the use of other life prolonging measures. When it comes to organ donation, even if a donor card is signed, family member may still need to sign a consent form. To prevent any ethical conflict, the medical care of the potential donor and the need of the recipient are always kept entirely separate and performed by completely different physicians. That conclude our comprehensive review of parenteral nutrition support. Thank you for your attention and see you in next lecture, next chapter, and goodbye.